I think we still have to proceed. Most welcome to this afternoon session. And I'm so happy that you have made a choice to be in this room. And coming from lunch, there are two things that are involved. Either you be attentive or be praying for us. So let's be together. This concurrent session will be looking at demand generation, issues to do with continuation of the discussions that we had since yesterday about vaccine equity. So I have very, very able presenters and the exciting presentations that will be happening this afternoon. I know that we have also different expertise in the room. We really need that interaction so that we have that discussion to move forward our work. So without wasting much time, we'll be calling upon the presenters to join me on stage, and thereafter we'll have the presentation. The first presenter this afternoon will be Thiaba. She's working with International Federation of Red Cross and Red Crescent Society, and she's a risk communication and community engagement coordinator. Most welcome, Thiaba. Are you freezing? And the next presenter will be Dr. Raveesha Mugali. Dr. Raveesha is a health specialist on immunization, working with UNICEF. We can give a round of applause. That's very important also to keep ourselves warm as we are moving our arms. The next presenter is Dr. Shuro. She's the evaluation coordinator working with VillageReach. And virtually, we have Vivian Bianco. She's a social and behavior change specialist working with the UNICEF Region Office for Europe. Hi, Vivian. Thank you. And the next presenter will be Dr. Corina. She is associate professor working with the University of California in Los Angeles. And I'm still missing one. Oh, she's now here. Yeah, okay. Most welcome to, let's give a round of applause to Dr. Oria, Associate Professor, School of Population and Health, University of New South Wales. So as indicated, this afternoon will be a very, very exciting moment. We'll have good presentations and also good discussions. I know that you have questions before even the presentations. Do we have some questions? I know some people will always have questions, even before the presentation. All right, without wasting much time, let's proceed now to our presentation. The first presentation will be from Thiaba. She'll be presenting in terms of strength and partner. Her presentation will be based on the using real-time community insights to inform and adapt plans and strategies to improve vaccine uptake. And let's have that presentation now. Over to you, Thiaba. It's your time.
Thanks.
Yeah.
All right. Can everyone hear me? Great. Perfect. Thank you so much. All right. So my name is Thiaba. I work for IFRC. I am the risk communication and community engagement coordinator for a COVID-19 vaccine program called Saving Lives and Livelihoods. I will tell you a little more about that later. But today, my presentation is going to be about how we have leveraged our experience from both Ebola and COVID-19 to ensure that community feedback and social data become a form of evidence that is recognized, that is being used by decision makers, and also to guide preparedness and response during any sort of public health outbreak. So we all know here that risk communication and community engagement are essential to any epidemic response. And obviously in the last decades plural, there's definitely been a consensus in terms of understanding and accepting that we need to understand what community members' concerns are, what kind of life-saving information they need in order to make the best decision to save themselves and their loved ones. What are the perceptions of the responders? However, we have faced, well, we're still facing a few challenges, including how do we gain community trust? How do we move beyond messaging? How do we find balance between, are we sharing enough information? Are we overwhelming people with information? And most importantly, how do we collect data in a manner that is empathetic, meaning that we don't just collect data to draft a few strategies and then we leave. How do we make sure that the data that we collect is something that people see that we take very seriously? So the 2018-2020 Ebola outbreak in DRC was very eye-opening for a lot of humanitarian organizations, including IFRC. And during this specific outbreak, we have learned the very hard way that communities' trust is very sensitive and it's fragile. Communities that do not trust the responders, that do not see the adding value of the response, will sometimes resort to violence to express their concern. So at the time, what we did in order to improve a critical situation, IFRC, DRC Red Cross, and US CDC worked together to plan, design, and establish a system to collect, analyze, and act upon community feedback to the response. So basically what we did is that we took the lesson learned from this particular experience and we apply it to COVID-19, and that's what I will be talking about today. This is a flow, this table here shows the flow of information and collaboration between the communities, the DRC Red Cross, the IFRC regional office in Kenya, but also all the responders that were actively involved in the response. And the intention was really to make sure that the information was available as quickly as possible, not just for the volunteers or for IFRC or the Red Cross, but all the implementing partners, all the people that were involved in the different pillars of the operation. And just to give you a few numbers, more than 1 million qualitative feedback was collected at the time by the Red Cross volunteers. And obviously, like I said before, the feedback was coded, analyzed locally. That's super important, and I'll get back to you on this. And reported on a regular basis to all the humanitarian responders for quick, and that's the key word, operational decision making. So maybe another piece of information is that at the start of the outbreak in 2018, the DRC volunteers were refused permission to perform at least 69% of the safe and dignified burials. So after we scale up the feedback mechanism, and after the volunteers started practicing intense community participation, making sure that family members were allowed to participate as safely as possible in the burials, the rate of successful, safe, and dignified burials increased to 92%. At the time, this was a substantial increase and a substantial way forward. And as part of COVID, we wanted to see what had worked during the Ebola outbreak, what did not work, and make sure that we provide all the tools, all the trainings, whether it's face-to-face or whether it was through webinars, to the national societies. So I don't want to spend too much time on the tool, but basically something that is worth mentioning here is that no personal information apart from the regular demographic variables were recorded because we did not need and we did not want to be able to identify the responders. So something very simple was used in terms of form. We provided log sheets to volunteers to manage the feedback. The coding framework is the most important aspect of the tool because it actually helped in terms of designing the different labels, the different categories, and because of the framework, of that particular framework, we were able to extract and extrapolate trends and patterns. And those trends and those patterns are what we were acting upon. We talked a lot this morning about listening. There's no point into listening to communities if we're not acting upon it. It's a matter of trust, it's a matter of accountability. So like I said before, the data was clean, coded, and shared on a regular basis. And at the time we created the dashboard. Everyone loves a dashboard. This is ours. So before, I don't want to spend too much time on the dashboard, but maybe something that I would like to share very quickly before I go into more example is that we did not start from scratch. A lot of the national societies were already collecting feedback data, but what we did and what was substantial for us is that we did it in a systematic manner, we documented it, and we did it at a very fast pace. I think this morning we talked about trust, and how we build trust with communities is no different from how we build trust with a partner, a sister, a colleague. It's a matter of, are you trustworthy? The information that I share with you, are you going to treat it with respect? Are you going to treat it as something that you care about? It's a matter of taking and giving, but it's a matter of listening and acting upon what we can act upon and making sure that people do believe our words when we say that we will do something to help them. So I'm afraid I don't have time to go through all these examples, but I could easily give you an example from every single 54 national societies where we operate. But I just selected a few that I thought was interesting. So in DRC and Lesotho, for example, our national societies did find innovative ways to adapt COVID-19 vaccination activities, and they did so by engaging intensely with existing local networks and networks with whom have very strong ties with the communities. So in DRC, for example, the volunteers, maybe let me clarify something about the National Society's volunteers. These are not people that we choose. Volunteers from every single national societies are handpicked by the community. So these are people that they trust, they listen to, they feel comfortable sharing their concerns with. So in DRC, mothers group who shared concerns about vaccine uptake, fertility, children vaccination. So these mothers group later on became active community feedback champions, but mostly COVID-19 champions. And in Lesotho, public transport drivers, were active and critical stakeholders in the sense that not only they were critical during COVID because they were actively transporting patients, but they later on became serious COVID-19 champions. Okay, so in some of the feedback that we used to collect were out of the scope of IFRC. Just to give you an example, in Cameroon, especially up north, where we had a lot of difficulties in terms of accessing and being in touch with very hard to reach populations, people were complaining a lot and sharing feedback about access to water. WASH and water is not something that IFRC, it's not our scope of work. So what we did is that we did share and we did discuss with the national coordination. We collaborated intensely with IOM, and as a result of that, boreholes and water tanks were installed for these communities. So it's not because we don't distribute water or we don't distribute food that we just, leave alone this kind of feedback. We act upon it the best way we can when we can. I could give you other examples from Ethiopia and Congolese Red Cross, and we have colleagues from the Ethiopia Red Cross here as well today. And basically the idea was really to push in terms of engaging people that communities listen to. In Ethiopia, it was community leaders that were paired with trained volunteers, and together they worked to establish a more how can I say that? Oops, I forgot the word. A more base or community-led feedback loop. In Congo, for example, we receive feedback from people living with disabilities, people that are deaf or blind, sharing with the volunteers that they feel like they're not part of the solution, they're not part of any activities that were conducted. So a team of professional and non-professional artists worked together to perform and record shows. So the idea was to be a little more creative and make sure that people feel like they were involved into something that affected their health. So I don't want to spend too much time on this. So challenges. So obviously we face a lot of challenges, and probably the most relevant one was the coding data. So I think a lot of us here have okay, I still have time? Oh, okay. Okay, please, okay, thank you. So coding was definitely something that was difficult, because for those of you who have done social science research, we know that coding is inherently very subjective, right? So when a large group of people are involved in the coding data, sometimes it can skew the results. So it was really, really important for us that the coding of the data and the analysis was done at community level. So the coding framework was co-created with the colleagues from the DRC Red Cross, from the volunteers as well. Confidence is complex. And I think we've been talking about this a lot in the last couple of days, because it requires, or at least it entails, a wide spectrum of drivers and barriers. So we definitely need to tackle vaccine hesitancy among people and groups who have the capacity to influence wider groups. Paper forms, when we talk about access to smartphone, we also talk about it's only a few segments of the population, especially in the areas where we work, that have access to smartphone. Men that are educated, meaning that people over the age of 60, women, younger girls don't necessarily have access to smartphones. So it's also a matter of how do we reach out to those segments of the population. Something that was mentioned this morning, and I was really happy to hear that, is vaccination is not a social norm everywhere. In a lot of the places where we work, people are more familiar with children vaccination, and they're more or less happy to proceed with that. But when it comes to adult vaccination, it was very difficult in a lot of the places, and it was a new experience. And new experience means that we really have to push for it. So what did work? A lot of things work, but basically it was just a matter of strengthening existing data collection and existing trusted channels of communication. So we did not reinvent the wheel. Basically, the only thing that we did is that we came up with a system that works for everyone and that is transferable elsewhere. I will not have time to talk about the rest of this. Triangulation of data is actually extremely important. Because it means that we don't abandon what has been done in the past. We don't put on the side the face-to-face interaction, interviews, stuff like that. It's just a matter of putting in place and establishing a system that is a little more structured and a little more systematic. Okay, that's it, I promise, that's it. Okay, while you're coming, let me go through the lesson learned. maybe if I had to choose maybe 3 lesson learned, it will be that community feedback data is good enough. And I do challenge anyone that will tell me otherwise. It matters in the sense that it's coming directly from the people that we are there supposedly to assist. So we need to work, all of us together as a collective effort to make sure that community data is normalized as a data stream and as a critical source of evidence. And I guess the last point that I can say is respond for localized needs, meaning that the COVID is no longer an emergency, but COVID is still right here, right now, and people have other needs and other priorities, but vaccination strategies need to change over time according to community needs. So I guess I will stop there. Thank you.
Thanks so much for that beautiful presentation. I know we have questions, just keep them, but as a chair of this session, I think I have privilege to ask some questions. So to keep you awake, I just want to know, you'll respond later on, in terms of, we are collecting a lot of data across the countries, very rich data. How are we utilizing the data to feed back in terms of the countries? To learn from each other, what kind of network is there? You respond later on. Ladies and gentlemen, let me now introduce the next speaker for this afternoon, Dr. Raveesha Mugali. Dr. Mugali works with the UNICEF as a specialist in immunization. And looking at the data from Cambodia, is doing especially well in terms of the COVID-19 response, as about a 9% coverage for the primary series, and they have also managed to cover about 70% in terms of coverage for boosters by December. The figures would be a little bit higher now. And the UNICEF has supported the Ministry of Health in vaccine delivery and management, risk communication and community engagement, as well as capacity building, local planning, as well as community outreach. Dr. Raveesha has been led the response from UNICEF, and today he'll be sharing us in terms of rapid community assessment as an effective tool in terms of identifying, understanding, as well as reaching the missed communities, especially during the pandemics. So, ladies and gentlemen, Dr. Raveesha.
Okay. Good afternoon, everyone. So my presentation will be having 3 segments. I don't want to put you in sleep. So it will be little visuals and data heavy, but you need not have to look everything to understand, but I'll say the messages in terms of the time. Thank you. So I'll be talking about the exceptional COVID-19 response of Cambodia, just in the visuals, and I'll talking about rapid community assessments, which helped to identify the missed children, missed population with the COVID vaccination, and how did we use it, and so how did we address it, and also taking the learnings from the COVID, whether these tools can be utilized for the routine immunization for the zero dose agenda. So these are the 3 segments, and let me see. I'll run fast. Be with me. Right. So this is COVID. Yes, I have plotted this GDP in the lower x-axis, and the y-axis is the fully vaccinated population, and see in the right upper corner, that's the month. So for the December 2020, the Israel and few of the countries are going up with the vaccination. And if you see the right side of the picture, most of the countries, with high-income countries, have reached more than 80% coverage over the period. But if you see, the Cambodia is one of the shining star, so of the lower middle income countries with the GDP. so which has reached that higher coverage within, actually in August 31st, Cambodia was on almost an 80% of adult coverage of vaccines. How did we do it? So, the very special strategy called Blossom strategy, which is being deployed in the country. So that is actually the first vaccination. So first we started with a capital city. So it's 2.2 million population. They started first capital city, and then the neighboring provinces, and then the whole country. And if you see the in August 18th of 2021, so Phnom Penh is the most vaccinated capital in this world. So, and also if you see the right side of the graph, so over the week of 11th August, Cambodia has been ranked #1 globally in terms of vaccine doses per capita. So that, and if you see this slide, so I just focus on the lower graphs. So where within August 5th to August 19th, 2 weeks, so we could able to reach very good coverage across the provinces. So that was happened because of the, warp speed vaccination. So that is with not only health systems, and also military got engaged to deliver these vaccines. So, and if you see the COVID important metrics across the countries, we have plotted 175 countries, excluded only countries with less than 10 million population. So if you see the cases for 1 million, so the black dot is the Cambodia, and rest is the world. So if you see the deaths per million population, it's here, and fully vaccinated as of as a percentage is here, and so the willing to vaccine is here, and then total days in the lockdown, it's here, and there is an average Asia Nikkei recovery index where every month. So Nikkei will give this index considering COVID, not only COVID vaccination but multiple COVID-19 response. And Cambodia topped over the almost 90% of the times. So another very unique thing about Cambodia is the only country globally to have surpassed these three thresholds. Over 70% fully vaccinated in 2021 and then under 100 deaths in 2020 by making strict measures, and under 50 days of lockdown. So this is an exceptional story of Cambodia. So I'll go to the next segment before going to the last slide here. At the moment, Cambodia has implemented 6 doses and up to the 3 years of age group. So, and I was talking now to shift into the next segment, that's the rapid coverage assessments, rapid community assessments. So this is the period actually when we started, when we started looking at data, data already more than 80% of the adult population have been covered. And so these are the types of the surveys what we had. But this is the time we thought about to design something to see 0-dose COVID-19 vaccination population. Where are those people? So the objectives are to identify the population who are missing COVID-19 vaccination in a high coverage setting, to understand the barriers these population facing in accessing and utilizing vaccination, and also to ensure missing population are reached with the vaccination services with appropriate strategies. So to make this happen, so this is the methodology we deployed. Only 2 key points here. So it's a purposive sampling. We have to zoom in where are those populations are. So we took a 3-level purposive sampling: national level, provincial level, district level. Go to the data and find out which provinces are doing low coverage. And we went up to the lowest health facilities and village level data. And with that, so purposively sampled these sites in operational districts, and we went to the 87 communes. These are the maps showing, these are the communes where we have to, so I mean, with the methodology we got it, so where we have to do these assessments. These assessments involved the local, CSO members, health staff, and also some of the VHSD, the community health workers, and health staff. So it's going to the area or a village or a market, and if it is in a village, we are going to look at 20 random houses and getting the data. So of all household, of the whole household, and the vaccination in terms of the coverage, in terms of barriers, in terms of what are the channels of communication they use. So we developed the questionnaire and we made a real-time data entry with a ODK owner tool. So that was deployed. And the survey results, to make it simple, I know it's an afternoon session. So yeah, we covered 121 villages, areas, 2,420 households, 86, actually 13,000 data, 13,000 population totally were surveyed. So it shows 86% of the coverage of the primary vaccine doses, and there was 7% zero dose. So, in terms of the barriers, these are the important barriers. I'll show in a different chart, particularly. And these are the 87 communes reached. So, and this slide I am not going to present. This is the dashboard. But so we also had a component of qualitative study, deep dive qualitative study, taking it from the data, and the highest coverage. 11% is this province with the highest zero dose children, and we selected for a qualitative study. And so this is also the total summary of how did we do. So we can go, I'll skip it. And socio-demographic characteristics. So actually we looked into all parameters possible with, but important thing is the first one is the poverty. So there is ID poor and no ID poor, and education, no education, primary education. So and another important thing is pregnant and lactating women, and households, and less than 3 years, migrant population or not. So, and then disability, sex, ethnic group, age group. These are the characteristics. I will not go in detail of that. So, but whom we are missing? Who are the zero dose population who are missing? So 9% in the ID poor population are missing. So in primary education, so the people with no education, 17.8% of the population were missing. And pregnant and lactating women, 11% are missing. And so health condition, comorbidities, around 8%. And migrant also 8.4%. Disability, 20%. That is the big chunk. So these are the population missing. These are the 4 themes which came up, and these are the 4 main barriers: concerns about the health conditions, and concerns about the adverse effects of vaccination, was busy, and being pregnant and lactating women. So for the booster dose, these are the main, again, important thing, but the being busy is one of the important barrier. So what did we do? So, and also we come out with this information. So these are the population which are most deprived, and the communication channel for them is they got information from the local village authorities, VHSDs. VHSD is community health worker in Cambodia, and also the loudspeakers in the community, TV, radio. These are all coming later, but the member, friends, neighbor. So these are the important aspects we got it. So in summary, what did we get? Key population characteristics of the zero COVID-19 vaccination people are with the poverty, with no education, ethnic minority group, disability group, pregnancy and lactation, and comorbidities. So it's very clear, and then so we presented that data into each province. It's not at the national level. So, and then these are the things we came up with. So with a discussion with the provincial health authorities, okay, top barriers are these 4 things. So what did we do? Immediately we trained and oriented oriented 453 frontline health workers. That is most important because they are the one who are giving the vaccines. And pregnant and lactating women and comorbidities, that's the place we have to take the measure. And also the revised and updated RCCE messages, intensified targeted interpersonal communication, and particularly the word of mouth. And very important two aspects. One is we flooded the media, flooded the social media, and all other things, mainly for the friends and neighbors to go across and get this information, pregnant and lactating women, because earlier the WHO has not yet given that, the approval of, when the early vaccine came in, and later it came in. So that's why we wanted to remove that misconception from the community. So for that, we flooded with the information with almost 157 materials we prepared. Another important thing what the provincial authorities did is, so particularly for the remote farthest villages where travel is an important challenge, they decided to make a team, the village, and they will go and stay in the remote villages and spread the news, and overnight stay, and 1 or 2 days, so neighboring villages, and come back. So that also worked. And for the communication thing, actually, UNICEF Cambodia has won the six Grand Steves Award. It's an ultimate award of the Steves. And actually, with lot of information, data, and this one. So one of the jury members wrote, actually, amazing achievements, science-based, timely, and targeted public information campaigns saves lives. So this is my second segment. So I'll take... Yeah, so RCA give that impetus to tell us, okay, these are the 4 important categories we have to work on. So we adopted this and reached out to the provincial health authorities with the feedback and discussion and channeling the resources. So that's the RCA, and if there is any questions and other things, I'll be happy to answer later. And third, final segment, it's I'll take 2 minutes, and how we can use this RCA for routine vaccination zero-dose strategy. RCA, why it is highly relevant is Cambodia has got 86% of coverage when we started RCA for COVID-19. Even now, so the routine immunization is also 90 plus. So, and our zero-dose children are 8%, 92 to, actually it was 94, and it decreased 2%, to 94 to 92, it's 92% now, and there are provinces. But we know that provinces, this data, it's not easy to implement, identify zero-dose children. And we also see, this is another slide showing, okay, there's no animation here. There are 10 multiple deprivations we mounted on zero dose. So like immunization, ANC4, SBA, stunting, wasting, basic water sanitation, poverty, school education. And see all the provinces. So there is IS deprivations. And after taking these deprivations, still gone into the operational district level. So where are we missing these children? And we came out with, so these are the 17 operation districts. So the migrant population here, ethnic minority, and urban poor, remote rural poor. So these are the 4 important 17 ODs where we think that the zero-dose communities or missed children are more. And we want to deploy multiple deprivation. Zero-dose lens is a proxy trailblazer for universal health coverage. We're all looking at no one left behind, and more cross-sectoral collaboration is needed, and innovative models are needed, and more evidence generation, drive policy and dialogue. And particularly what we're looking at is 2 things. One is we'll do the rapid community assessments, and also SCD tip for that. And the last, from Cambodia's success, we have learned how to vaccinate and ensure no one is spurned. Rapid community assessments serve to identify and reach those who need to be reserved. Digital tools aid in data collection and help to monitor vaccination. With RCA as an example to follow, we can keep the missing ones vaccinated and hollow. In this fight against pandemic and epidemics, let us continue to be enthusiastic and empathic. Thanks.
Thanks so much. That's a challenge when you're having 3 presentations in one. But you managed to cover it. Thanks so much. Just a quick question, which we may take it later on in terms of how can we utilize the same approach in terms of reaching out to zero-dose children. That's just a quick one. All right, are we still here? All right, interesting findings, the visualization and other things. Now we are going to another presentation. Let me call upon Dr. Linda Shuro to make a presentation. And she is a postgraduate fellow within the School of Public Health, University of Western Cape in South Africa. And as an academic partner working with VillageReach, she's helping to evaluate multi-site, community-based participatory research to identify drivers and scalable solutions for immunization access and uptake in low and middle-income countries. So she'll be sharing a presentation on evaluation of community-based participatory project to identify barriers of childhood immunization uptake and generate community-led solutions in Zambezia. Zambezia is in Mozambique. So, ladies and gentlemen, Dr. Shuro. And I'm giving her 5 minutes. I'm just
Okay, thank you so much. I'm going to try to be as quick as possible because we can see the time from here and it's flying. So my name is Linda Shuro. I'm part of the School of Public Health, University of Western Cape, and I'm working with VillageReach. So I'm presenting qualitative results of an evaluation of a community-based participatory research project in Zambezia province, Mozambique. So basically this project, the broader project is trying to amplify caregiver and health worker voices in terms of identifying barriers and targeted solutions. So there are 3 phases to it, that is identifying the barriers and solutions, implementing the solutions, and evaluating. So the project is using community-based participatory research and human-centered design. And VillageReach, as the implementing partner, has partnered with academic partners, University of Western Cape and Cape Town, to evaluate so that we can provide some evidence of best practice for replication and scalability. That's just a timeline. We're also working in Malawi. So in terms of the project in Mozambique, full immunization coverage is a challenge, especially for multiple doses. And in Zambezia province, in these 2 districts that they're working, Gile and Namaroi, nearly 20% do not complete routine immunization. So the project looked at identifying drivers of routine immunization using participatory data collection, photo voice with caregivers, and SMS exchange with healthcare workers. Then it went on to do human-centered design workshops, ideation workshops, and prototype to identify solutions. And the good thing about the project is it worked with multiple stakeholders, community leaders, healthcare workers, health officials, and we are evaluating that approach and the solution. So we have baseline, midline, and endline, and this is just the baseline for the approach itself. So going on our evaluation, it's a process evaluation to see to what extent this approach is really engaging with the communities. Is it really using that community-based participatory research and human-centered design in those 2 districts? And so we interviewed 46 participants, caregivers, community leaders, expanded immunization officials that were part of it. And we triangulated those interviews with feedback surveys, observations. Our analysis actually worked with some frameworks such as the RE-AIM framework, which defines implementation outcomes of REACH, effectiveness, but we also used other frameworks like the CIFA framework, which looks at relative advantage. We received approval in both countries, in South Africa and in Mozambique. So just as key findings, this is very high level. There's a report which you can read. The approach is called Batebapo, which means let's talk vaccines. It had relative advantage. It was seen as a new vision and a collaborative way of identifying drivers and solutions. And what was successful about the approach is it had a diverse and transdisciplinary study team. So that consisted of the provincial health officials, like the expanded immunization officials. It had the local government department. It also had VillageReach in the country and globally. And collaborative activities were done from the protocol development, the IRB protocol development, the planning of the tools that were used for the data collection, and also for solution design, and even the training. The EPI officials were involved in that. So it was really perceived as improving capacity and coordination. And that quote from the healthcare worker who was involved actually says, I think it's a project that came to change something, and I can already feel that change. The most impressive thing about this study is that people from the community, it got to describe the problems and then propose solutions. So this is a summary of the role of actors that were involved in the Batapapa approach. It recruited caregivers as researchers to be central to the data collection for the photo voice with the caregivers and the SMS exchange with healthcare workers. VillageReach was an external facilitator, and caregivers, community leaders, and APEs, who are the community health workers in Mozambique, were part of the community mobilization to really get it accepted. And provincial and district health officials were involved in connections and training, and also part of integration. So as part of Fidelity, community-based participatory research has got principles that are part of it. And this table just shows that the approach substantially adhered to the community-based participatory research principles. There were some limitations with the equitable partnership because the caregiver researchers only came in after the RB approval was done and the data collection tools were approved. But thereafter, they were involved in the data collection, in the co-analysis and co-authorship of an article based on that. And then the last principle, issue of sustainability, when we evaluated, we didn't see much of it. It was a limited degree, but there was initial planning around it. Thank you. So high-level findings from this evaluation, based on the re-aim domains. The approach really had extensive reach because there was a representation of a diverse study team. The caregiver researchers were central to the data collection. They were part of virtual debriefs, they were part of co-analysis, they were part of coding the data, writing reports, and being engaged with the community. So that also brought trust within the community because they spoke the local language, and so community leaders could trust them on that. And there was a mix of participants with the human-centered design ideation workshops. Like I mentioned before, health workers, there's Red focal points who are part of the immunization program in Mozambique. Then also from our evaluation from the views, there was also early effectiveness. This was just the approach, but now they're implementing the solution. But already bringing people together brought that increased coordination and positive relationships. Even improved communication with the service providers and the community leaders now that they could communicate about mobile outreach to hard-to-reach communities. There were also positive perceptions on the approach, which we saw that it signals potential adoption of the approach and the solution because people saw it as a new approach, a new way of doing things, and also it was bottom-up. It involved the caregiver in co-creating the solution, and its participatory implementation, because caregivers had cameras and they could take pictures of their barriers. So it was really good in that. But there was also just initial hesitancy in terms of use of a camera and use of phones in terms of the information, but there was a lot of sensitization. And all these participants received training on human-centered design and community-based participatory research. And what was critical that we found from the evaluation is that there were a lot of empathy and power balancing activities, which really created an equal platform for that. The approach, we also noticed that there were some concerns with resources and a limited approach, because Zambezia is big, but it was only in 2 districts, and this is something that's being echoed out. So what were the key factors that led to the success of the Bate Papo? I won't mention all of them, but what was critical was the diverse collaborative core structure, which had the intended user, the caregiver, and the stakeholders that were involved. The participatory planning and implementation across levels, from community up to the national level, and use of very creative tools and engaging district and community leadership, and building capacity in the different levels. That was critical. And just one thing on the intangible is that within Mozambique and from the views, there's really positive and motivated leadership that's willing to drive the process. So if you meet with the district health officials and the community leaders, they are really, really eager to implement the approach and solution. So the must that we saw in terms of integration from the evaluation is that it's important to involve Ministry of Health from conceptualization of the idea and the project, because these are part of approvals and uptake of solutions. So if there is scalability of solutions, they have to be involved. Joint strategic planning, especially for funding, because for sustainability, projects need to go on, so there needs to be that. And involvement of the EPI managers at all phases. That's very critical for integration. So in terms of wider implications for the approach, when using HCD, have simple manuals with simple terms, because terms like prototype can delay progress in designing solutions. Collaborative partnerships are important for adoption. And the methods have to be in tune with contextual reality. Like photo voice, we noticed that it was then accepted after a lot of filtration and sensitization. So methods have to be in tune. So my last slide is this approach really is promising in using CPBR and HCD approach to get solutions in that given community that are feasible. And that strong sense of ownership and consensus of the approach signals potential adoption. So that's our evaluation. There's a full report which you can refer to, but I've tried to be as brief as possible. Thank you.
Thanks so much, Dr. Shuro. You are within time. Thanks for that. We can give another round of applause. All right, so we are running short of time. For the presenters, they have got interesting biographies. I will not go through them. If you go to the website, just check on their names, read through. Now we are going to have 2 presentations on HPV. I think there have been interesting discussion in terms of HPV vaccine. So we would like to learn what is happening. The first presenter will be Vivian, which she has joined online. She'll be talking about implementing a nationwide SMS reminder to increase HPV vaccination in Georgia. Results from my 5-arm parallel randomized control trial. So over to you, Vivian. You can talk about yourself in 30 seconds, then proceed with your presentation.
Hey, thank you. Can you hear me?
Yes, we can hear you. Proceed, please.
Okay, and I guess you can also see the presentation. There is a delay, so I don't know if you're actually seeing the presentation or not. Could you please confirm?
You can see it, put it on a slideshow.
Is it okay? Okay, so my name is Viviani, Vivi, that's how everybody calls me. So I'm gonna present the nationwide SMS reminder that we developed in Georgia to increase vaccine uptake, HPV vaccine uptake. So I'm gonna present the results of a 5-arm parallel randomized control
Vivian?
trial.
Can you
Yes.
stop sharing and share again? Because we are looking at your notes as well.
No, I don't know why you see the notes. Let me share.
Yeah,
this
that's better
screen.
now. Brilliant.
Oh, really? I don't know what's happening. I can only see the
Yes,
notes.
proceed. You have now 8 minutes.
Okay. All right. So I'm from UNICEF Regional Office for Europe and Central Asia. And I would like to acknowledge all the work done by UNICEF Country Office in Georgia, also our implementing partners, the Georgian NCDC, the Information Technology Agency, the Behavior Insights team from UK, and all these partners, they have been key for implementing the SMS in Georgia. And I would like also to thank the Office of Innovation of UNICEF for the funds for conducting the evaluation. So when we approached the Georgia country office and the country in general, we came with the objective of designing a behavioral informed intervention to increase demand for immunization. Then, of course, based on that, we had to define the problem. We had to really define the target behavior. And then we looked into some desk reviews, some literature. We discussed with the country office, we discussed with the national authorities, and we really identified that HPV vaccination was an issue that should be addressed. So the target was really to increase the uptake of HPV vaccination in the country. And of course, because of several issues related to HPV infection, cervical cancer, and also because the uptake of HPV vaccine is very low in the country. In 2021, it was 24%. So in order to develop the solution, in order to address the problem, we used a behavioral insights approach, and we started with understanding the barriers to HPV vaccine uptake. We did this through literature review and also through primary data collection. We had some in-depth interviews with caregivers. We also had some focus group discussions with health workers and observations at clinics. And here you can see the list of the barriers that were identified. So there are 9 barriers that were identified, but you can see that there were no reminders. The caregivers were unaware of the vaccine. The perceived cost of the vaccine was high. They weren't sure about the risks. So you see many things related to health, to caregivers, lack of knowledge, lack of understanding, but also lack of motivation of health workers. Of course, we were not able to address all the barriers with one solution. So what we did was to take all these barriers and go into an ideation workshop using human-centered design approach. We identified some caregivers, health workers, policymakers that could, together with us, look at those barriers and really brainstorm potential solutions to address the issues. Then we selected 2 prototypes. Actually, one was related to information provided by health workers to the caregivers, informing them and reminding them about the vaccine. And the other one was a letter to be given at schools. It was during the pandemic when we decided to move ahead with this project. And then, of course, it was not feasible to implement the letter at schools. So we decided to go ahead with this intervention that was supposed to be delivered by health workers to the caregivers, informing them and reminding them about the vaccination. And we did 3 rounds of pre-tests. The solution was initially both an SMS and an email that could be sent by the polyclinics in the name of the health workers, as health workers are identified as the most trusted source of information on vaccination. So this pilots up this three rounds of pre-tests, it really showed that the promise of the intervention. There was one polyclinic that got 78% of the caregivers going for vaccination. So we really saw that this solution of the health workers informing the caregivers about the vaccination was really promising. However, it was not sustainable, because the way that we were initially proposing the solution was really for the polyclinics to send the reminders themselves, and it was considered a burden for the health workers and the polyclinics to go ahead with that. So we decided to change it a bit, and we took a look at the existing system at the country, and actually there was a e-health system that was led by the NCDC. They were already sending alerts for vaccination, but HPV was not included in the list of vaccines for reminders. So what we did was to shorten the message and work with NCDC and ITA to deliver this SMS reminders. And of course, we wanted to evaluate. So what we did, because we had this information system which was available for us, what we did was to work on 4 different messages and do a randomized control trial. So there was one message which was just giving basic information about the child being due for vaccination. The other message was basically the same, but also adding a link to NCDC for more information. The third message was framed with a reserved for you, so that there is a vaccine reserved for your child. And then the 4th message brought a safety information plus the NCDC link. Of course, all these messages were developed considering the insights from our qualitative research and also from evidence from literature as well. So while we developed those 4 messages, we also worked on the content of NCDC, because through our pre-testing, it was found that the NCDC website was not that informative regarding HPV vaccination. So because we were sending the link for more information to the NCDC website, so we also did a very basic revamping of the content of the website. So then we went for the evaluation. We went through this randomized control trial. Then you can see the steps that were carried out. I'm not going to list all of them. You can see on this slide. But that was basically the process that we went ahead. So there were in the NCDC database almost 90,000 girls aged from 10 to 12, which was the group eligible for HPV vaccination. Then from those, some girls were already vaccinated, so we were left with 69,717. And from those, we had to have this the caregiver phone number, so we could link the intervention with the vaccination record. So then we were left with 55,000 more or less girls. And then we analyzed a little bit more than 54,000 girls that were randomized into this 4 or 5 groups, actually. So 4 different messages, and then a control group that received no message at all. And then, of course, we tried to measure after the randomization, the outcome, which was really the HPV vaccination recorded after 60 days of this trial period. And these are the results. So basically what we can see here is that all the messages performed much better than the control group. So it is definitely important to send SMS reminders. We had a total of 2,070 girls that received HPV vaccination during the trial, which was done for 60 days. The vaccination rate in the trial was 3.84% after 60 days, ranging from 20.4% in the control group to 4.7% in the version 3 of the message, which is the reserved for her framing. As I said, so the girls in each of the treatment arms were more likely to have received the vaccination than the girls in the control group with no SMS. And I know that it may be overwhelming, this graph, because there are several numbers, but the big number, the big percentage, so to the 2.4%, the 3.3%, and the 3.2, 3.8, and 3.2%, these numbers are based on an intention to treat analysis. The percentages are based on findings from logistic regression analysis and demonstrate the effect size of the intervention. So it means that if the control group had received the version 1 of the message, it would have been 3.3% instead of 2.4%. If the control group would have received the version 3 of the message, which is the reserved for her framing, the result would have been at 3.8%. I know it's a bit complicated, but that's how this analysis is done. So actually, it shows that there is if the most effective version of the SMS, which is the version 3 reserved for her, had been sent to the control group, we would have seen an increase of 1.4 percentage point, which is a relative increase of 58%. So these results that we were managing, where we managed to find through this RCT, they are consistent with evidence from other parts of the world. We missed this evidence in this region, Europe and Central Asia, so it really adds to the evidence that we have in this region. And so the other insights from previous research really suggest that reserved for her, reserved for you framing works. The intervention achieved a substantial effect size. As I previously mentioned, the effect size of the intervention was 1.4%, but we need to be aware of that it may seem like a small scale number. However, the relative increase, as I already said, was 58%, which is huge, because from previous literature, we're actually expecting a relative increase of 29% more or less, and we actually saw a much higher relative increase. It's also important to consider that were sample characteristics that we think that actually contribute to undermine the results, because the intervention was basically like a recall campaign. The caregivers that received the message, they were already, their kids were already due for vaccination. So probably they were hesitant, like they had a lack of understanding of HPV vaccination. They were more likely to be hesitant than caregivers who would only receive the reminder in case the child was due for vaccination, right? Instead of being late for vaccination. And it's also important to mention that our results are very conservative, because during the randomization, we actually randomized looking at the child and not at the caregiver. So this led to some caregivers in the control group receiving the SMS reminder, because many girls had siblings. So the caregiver in the control group, they actually also received the reminder because of the randomization not being done at the caregiver level, but at the girls level. So actually, it also shows that our results, even though they're great, they are probably even greater if these kind of errors didn't happen in the randomization. And it's also important to notice that the SMS reminder was extremely cost effective. Of course, the Georgia NCDC, the country already had the SMS system, but it was very cost effective to actually send the message and reach the caregivers with the messages, and then see the vaccination rates really increasing. So this is the message, you can see there. This is the final message that was adopted. Your daughter is due for a free human papillomavirus vaccine, which will protect her against cervical cancer. Her vaccine is reserved for her at the polyclinic. Contact them today to arrange an appointment. More information on the official NCDC website. is available. So this is the message. And actually, after the evaluation, we had discussions with NCDC, Ministry of Health, and they have decided to use the most effective version of the SMS, which is with the research for her framing, with all future cohorts of 10 to 12-year girls when they become eligible for vaccination. And they will also use this framing to send the reminders for girls who have missed vaccination who are between 13 and 12 and 18 years old. So we really see the potential of this being, reaching more kids and then leading to more vaccination. Of course, it's important to notice that this intervention is focused on some areas.
Vivian,
and there
can
are
you hear
other
us?
areas Sorry?
Yeah, I'd like to request you to conclude because of time.
Yeah, I was just going to say that there are other barriers that need to be addressed in the system, and we continue to work with the government to address them. So that's it. Thank you.
All right. Thanks so much. Thanks so much for the good presentation. Just hang on. We'll have question and answers at the end. From Georgia, now we are moving to Kenya. Let me call upon Associate Professor Dr. Corina just to take us through a presentation in terms of factors affecting uptake, lessons, I think, from Kenya. So, Dr. Corina, it's your time. You have
2.5 minutes. Okay. I will try to be extremely quick. Thanks, everyone. I know we're standing between you and coffee. I'm going to talk to you about a survey that we did in Kenya to understand factors associated with HPV vaccine uptake. I'm going to basically skip this introduction because of time. We know HPV vaccine is extremely important. We know that there's a huge equity gap. We don't really understand very well the factors that are associated with low uptake, particularly in low middle income countries. And without understanding that, we can't design effective interventions and policies. So we undertook a study in Kenya to look at which factors are associated with uptake of HPV vaccine in that setting. We did a random digit dialed mobile phone survey between August and November of 2022. Eligible respondents had to be a parent or a caretaker of a girl aged 10 to 13. Kenya introduced their national HPV vaccine program in 2019. So this was capturing for 10-year-old girls. So this was capturing girls who were currently age eligible or had been age eligible since the national program was introduced. And the respondent had to be aware of that girl's HPV vaccination status. And I'm saying girls here because there may be more than one in the household, and so anyone in that age range, if you had one or more girls in that age range, then you were eligible to participate. This is the cascade of our sample. We had to dial over 18,000 phone numbers before ending up with 1,400 people who completed our survey. And there's 1,347 people whose data made it into the analysis that I'm showing you today. Oral informed consent, phone survey, IRBs in the US and at KEMRI in Kenya approved the study. Okay. The variables we looked at, so our dependent variable was whether the girl or girls had received any doses of the HPV vaccine. We actually collected information on all doses received, but we were particularly interested in this uptake issue due to the new WHO recommendations for a single dose. And so we measured this any doses variable through parent report. So we asked the parent if their daughter or the girl in the household had received HPV vaccine, and we asked if they had the vaccine card available. Very few did. So in most cases, this was based on parent report and recall of whether the girl had received doses. We asked when, we asked where, et cetera. We were curious if parents were sort of reporting this accurately, and so we had a nested sub-survey where we actually asked the girls if they had received HPV vaccine, and we looked to see if these two reports were correlated. We thought they would be, since this is like a highly differentiated event, right? Girls this age are generally not getting a lot of vaccines. It seems like everyone would sort of know and be aware, and indeed that was true. There's over 95% concordance between parent report of uptake and girl report of uptake in the same household, so that was reassuring. Independent variables here were informed by the WHO BESD model. I'm really not going to walk through this. We've been through BESD many times over the past couple of days, but I'll talk about sort of each of these. We looked at constructs within the thinking and feeling domain, social processes, practical issues, and then this vaccination outcome at the end, using validated tools from other settings because there's been very little validated work on HPV vaccine constructs and LMICs. Okay, findings. So we found that in this sample, HPV vaccine coverage was very similar to, maybe slightly higher than the administrative data. So that was reassuring. About 38% of girls in our sample had reportedly received any doses of HPV vaccine. Among those who had received any, 58% did the full course of 2 doses, 42% had received 1 dose. Interestingly, we didn't find many demographic correlates of HPV vaccine uptake. We did find that mothers reported this more often than fathers did. And interestingly, we found that people in rural areas reported this much more commonly than their counterparts in urban areas, a fairly strong gradient. Only 27% of our urban parents said that their girls had been vaccinated. 56% of our rural parents said that their girls had been vaccinated. So, and towns are somewhere in the middle here. So we're seeing this very stark trend that perhaps runs counter to many of the things that we typically think about vaccination. So I find interesting. We didn't see any differences by parent educational attainment, by SES in the household. So this sort of urban-rural thing seems to be standing on its own. I'm just going to note quickly, access problems, on the far right of the BESD, were reported very infrequently in this sample. Less than 10% of parents said that they had either had a problem with access to the vaccine or anticipated a problem, so I'm not really going to talk about it. Kenya had been offering the vaccine through health facilities and transitioned to a school-based approach, and so that kind of mixed model may be one of the reasons for the general high availability of the vaccine. We found that parent attitudes and knowledge were associated with uptake of the vaccine. Parents generally were very enthusiastic about HPV vaccine being important and effective. Not a problem there. But about half were concerned about short and or long-term effects. And we actually, in this survey, we split out asking about different types of effects because we've heard these issues with fertility concerns. That's obviously very different from I think my daughter will get a fever this afternoon, which is also very different than I think my daughter might have a stroke this afternoon. So we tried to kind of tease apart severity and duration. And about half of parents said that they had concerns in both of those categories. We sort of summarized all the attitudes and beliefs into a single vaccine confidence score, and we found that having lower confidence was associated with lower odds of uptake in multivariable analyses, not surprising. We did a quick sensitivity analysis. We asked the same questions about your attitudes towards routine child immunizations, and that was not at all correlated with HPV vaccine uptake, so there's potentially something unique going on about your attitudes about HPV vaccine, which would make sense. I would say knowledge is generally fairly mediocre. It's sort of a mixed bag. But we did find that parents who had higher overall knowledge around HPV and HPV vaccine, their daughters were more likely to be vaccinated. So that makes sense. The more interesting results, I think, are about social norms. So, those effects I just showed you are interesting, but not earth-shattering. The social norms factors were very, very strongly correlated. So parents who said that they talk to other people about the HPV vaccine, they had over 2 times higher odds of having vaccinated daughters in adjusted models. So talking to other people seems like it's very helpful towards moving parents towards vaccination. And perceiving pro-HPV vaccination social norms was really, really strongly correlated with uptake in one's daughter. So perceiving that other people around you are vaccinating their daughters against HPV was strongly, strongly associated with your own daughter being vaccinated. Again, we wanted to make sure this wasn't just a personality effect. So we asked, if you perceived parents were vaccinating routine child, and that was not associated with HPV vaccine uptake. So again, there's something about the norm with HPV vaccines that seems to be associated. And generally being more trusting in institutions and especially more trusting in health workers, both health workers and community health workers was also associated. Okay, so summary of findings. Sorry, that was really a whirlwind. I think that probably the most important one is that talking with other people about HPV vaccine and feeling that other parents are vaccinating their own daughters against HPV were our strongest correlates of reported uptake. Knowledge and attitudes were also associated, and this sort of persistent safety concern that we keep hearing about was relatively common, about half of parents in our sample. Few parent-level characteristics were associated with either the determinants or with uptake, although there might be this rural-urban gap that I think is interesting and worth exploring further. So implications for policy and practice, I think we really need interventions that touch on these social norms. If indeed they are sort of so important, particularly for new vaccines, we really need to think about how to get people talking to other people about the vaccine and sort of opening up some of those social channels. One way to do that might be to leverage trusted messengers. Healthcare workers are a common one. We also asked about religious leaders. Interestingly, about half our respondents said that they would listen to a religious leader's advice on HPV vaccine, and that was true across religions and within Christianity, across denominations. So religious leaders may have a really strong role to play here. Like I've said many times, urban parents may need more attention, and this safety issue, and just figuring out how to message about safety in a way that moves parents and sort of changes attitudes there is great. So the study is supported by the Johnson Comprehensive Cancer Center. I thank them for their support. I thank our research assistants for dialing 18,000 phone numbers to talk to 1,300 parents. And thank you all for your questions. We probably won't have time, but you can find me the rest of today and tomorrow. Thanks very much.
All right, thanks so much. And the last but not least, our presentation will be based on the a qualitative study exploring strategies to enhance immunization uptake among the ethnic minority communities in Australia. I think there was a presentation I mentioned that there are over 300 languages in Australia. Over to you, Dr. Hori.
Thank you, and I'm again in that difficult position of being between you guys and food. So hi everybody, it's lovely to be back up and being able to talk. The panel here has just given 40 plus minutes of presentation. Karina, I think, spoke at a level that was probably very high. In that back room, we have 2 translators. They have just had to translate that language. No, I don't mean to call you out, but this is what we take for granted, is that everybody is listening to that language. So we've spoken a lot about communication. Communication isn't just about the platforms that we use to get our messages out. It's not about who is our messengers. I've had the privilege over the last couple of years to be working with a range of culturally and linguistically diverse communities. So that's the term we use in Australia. Ethnic minority, there's a range of terms around the world that are used. And they knew going into this pandemic that there was going to be inequity, that they were going to be caught out because the systems weren't set up appropriately to be able to have effective communication and engagement. They knew this quote was in April 2020. This alarm was going out to say, we've got to do something quick to ensure our communities are not left behind in Australia. Same around the world. Impact of COVID on racially and culturally marginalised communities. We had higher hospitalisations, we had lower vaccine uptake, we had lower levels of compliance with other strategies. These are the communities that were dying at higher levels through COVID. We've seen this again. Previous pandemics, we often see this with other vaccine-preventable diseases. So we went in and did a series of studies over 2021 and 2022 to try and understand from our multicultural communities what was happening when it came to communication and engagement efforts. How were we actually, what was working, what was not, when it came to how governments were trying to get out messages, including that about the COVID vaccine, into culturally diverse communities in Australia. This study included in-depth interviews, not with the community members themselves. What we were interested in was those organisations and those stakeholders that play a role in being what we termed information intermediaries, the go-betweens between government and community. We wanted to hear from them because we knew, and everybody here has reflected on that they do play a critical role in community in getting into groups that may not necessarily hear the communication messages in other ways. We wanted to understand from community leaders, from religious leaders, from community health workers, and from the community-controlled organisations, what was working, what was not. And we found a lot out. We found a lot out about the barriers. Obviously, some of this we knew, but some of this was coming out as novel findings. One of the first was that we were getting overloads of information coming from international settings. So our residents in Australia were not listening to the news, weren't listening to the radio, weren't looking at local newspapers. They were streaming them from countries of origin. So they were getting the messages that were coming from country of origin, and they were conflicting with the local messages. Not all community members were part of a community. So we have new and emerging communities in Australia, and the same as other countries, that are not necessarily aligned to community organisations, that don't necessarily have community leaders or faith leaders in their areas, that don't have the radios, the newspapers and all the rest of it, and they were missing out. But beyond that, also, obviously, we have those that are missing out because they're not connected because of the digital divide, that they don't have all the social medias at their fingertips. They're not on the internet. And so this is our elderly community members in our multicultural communities. Yes, there was lots of translation. We had so much translation, we were drowning in it in Australia. If they translated a resource once, they did it 20 times. Was that a good thing? No. Because what we failed to do was also support how we were getting those translated messages out into communities. We were also misunderstanding what was needed in the community. And you can see this as an example from the South Sudanese community, that there is not just one tribe in the South Sudanese community, that they are made up of 64 different tribes that each have nuances in their language. Yet we didn't pick that up into our resources. Yes, we had a resource in language. It became a tick box exercise. Was that resource meeting the needs of that community? No. It did not have the right language within it. It did not have the right terminologies. It did not resonate with these community members. So we need to go back to the drawing board when it comes to thinking about how do we actually select language? How do we work with language experts when we're putting together resources around immunisation? And this isn't just a pandemic space. This is about going back in and looking at all of our immunisation resources that are out there, the printed materials, the posters, the website materials, and actually having a look at whether or not they meet the language needs. And this isn't just about health literacy. Health literacy is a great thing, and we definitely need to make sure we are accommodating that. But that's not the only thing when it comes to making sure a resource is appropriate. We need to think about, yes, who are our target groups? We may not need a language resource in every language because our established communities can get it elsewhere. What we may need to be considering is our newly emerging communities, those that don't have those support packages, those support groups around them. And this is where we come to this idea of high needs versus high volume. In Australia, we have large volumes of community members who come from India, from China, speak Arabic, speak other languages that have been in, like Greek and Italian, they've been in the community for a long, long time. Whereas we have other communities, the Burmese, the Rohingyans, the Nepalese, they don't necessarily have those resources to support them in the same way. So they may be classified as a high-need community because no one's necessarily giving them the support to get the materials into their community. So we have got lots of infrastructure in some communities and very little in others. And this is especially critical when we think about those living in rural, remote areas as well. So we also overlook the fact that we have lots of communities around the world that are oral, that have an oral tradition, that have low literacy in their own language, and obviously they're no literate in any of the languages coming through. And we're not accommodating that at the moment either. One of the classic stories in Australia, beginning of the pandemic, we had a huge outbreak in a meatpacking service. And the government rushed in, they translated all of the resources into what they thought was the appropriate language. What they didn't realise was the staff members in that meatpacking office had an oral tradition. They didn't read in their own language. So we're just so quick to jump and say, let's translate, but we actually don't understand what's needed. So we don't recognise the importance of thinking about language and how we work with language. There is minimal consultation happening at the moment. This isn't a new issue. This has been going on for a long, long time when it comes to language. We need to think about our resources. We need to think about tailoring. And the critical thing here is that we have lots of communities now in Australia who have heightened levels of mistrust with government because what has happened. I'm going to skip that because I don't have time. I tried to help with this issue. I developed a glossary. I developed a glossary because we were making assumptions that the people we were asking to develop these resources and to translate them and to interpret them and to go and speak about these resources actually themselves had the understanding of what these terms meant. And when we talk about immunization, it is a complex language, like the terms that we use, just as something as simple as rollout. Does everyone understand what the term rollout means when it comes to an immunisation program? We might do in this room, but when we step out into our communities, rollout is not a term that translates well. So we use this jargon. We actually need to support those on the ground who are these leverage points into community, who are these information intermediaries to help them then speak the language of immunisation. That's available on the website too, if anyone likes it. 29 different languages, give it a bit of a plug. It's still available. I'd love to do one about immunisation more generally, so if you'd like to team up with me and do one, I'm all ears. Come and find me. Okay, so we need to work with our community ambassadors. We've been hearing this a lot. We need to make sure that they have the resources and capacity to speak about immunisation. We need to work more with linguistics experts. And golly, it's been a privilege to work with that group of researchers and with translators and interpreters, because we could learn so much. So yes, bring in your health literacy experts, bring in your communication experts, but bring in the people whose everyday job is to talk about language and how do we get better understanding of the different ways that we can unpack language and put strategies together better. I'm running out of time. All right, so I'm going to finish. Because I'm passionate about this, I really would love to engage more with others. I'm just about to start up a big 3 years worth of work around how do we better use communication and language with multicultural communities in Australia, and I'd love to see this work go worldwide, because I don't think we do enough about crossing out of our silo of immunisation and actually thinking about how do we bring those other learnings into our strategies around routine immunisation, around immunisation during emergencies, and more broadly than that. And if you'd like the papers that I've just been kind of speaking about, they were both available on free to download. So just send me an email, track me down, and I'll send them happily to you. And I'm also going to give a huge plug to my colleagues and the funding, obviously, from the Multicultural Health Communication Service. So let's go and have a cup of tea. All right. Thanks, everybody. Thank you.
Wow, thanks so much, Dr. Hori. We have wonderful presentations. We are running short of time. We are going to give the audience time to ask questions. Do we have quick questions? 2 from this side, 2 from the other side.
Sorry, I think unfortunately we started late in the morning. Can I ask, unless someone has a specific question for Vivian, who's virtually, can the rest ask questions at coffee and tea?
All right, okay. That's okay. So do we have any question for online presenter Vivian? Anybody? Going once? Yes, please use the mic. Vivian is still there? Right, yeah, okay.
Yeah, I'll just be quick. So Vivian, I just wanted to understand that since you mentioned different messages, like the most effective one, were you also, like, there must be other SPCC interventions going on. So were those taken into account for the, the increase that was happening? Was there a comparative analysis on those interventions? Whether those were, it could be that other interventions would be working. So was that considered during the study?
Did you get that?
Yeah.
Proceed to respond.
The goal of the study was really to understand the most effective message to increase HPV vaccination in that context. So we didn't consider other interventions, and basically all the messages were developed considering the findings from the research that was conducted, the in-depth interviews with the caregivers. So the safety concern, the lack of reminders, like the messages were developed considering those. So we didn't take into consideration other interventions. Of course, there are other interventions need to be in place. For instance, the UNICEF country office is supporting the government to implement interpersonal communication training for health workers. But this requires another type of evaluation. It's for a different target audience. So the messages, all the messages were considered only for the reminder. So that was the evaluation that was done. Which message from those four would have highest effect in terms of HPV vaccination? That was it.
So
we didn't consider other.
Yes. So my point for the audience here and you is, like, for relating it, the increase in vaccine uptake and differentiating between whether those, like, which intervention caused the increase would be, in itself another issue to address. That's what I wanted to point out here.
But the results, the evaluation, the randomized control trial really showed that each message was much more effective than sending no message at all. So only this finding in itself already shows that the reminders do work to increase vaccine uptake. What the evaluation tried to show beyond that finding was which message was more effective. And then we found that the message that had the reserved for her framing was more effective and led to higher vaccination when compared to all treatments and, of course, the control group as well. So definitely there was an increase in vaccine uptake given the intervention, for sure.
Thanks, Vivian.
All right, thanks so much. Let me thank all the presenters, and let me thank everyone for being a good audience. As indicated, we'll be having a one-to-one question and answer session during tea. So we'll be proceeding to the poster presentation, which will start in the next 10 minutes. So let's grab something to eat and move to the poster presentations. There are a number of sessions that are also happening. So let's give them a big round of applause for ourselves and the presenters. Thanks so much.